Good morning, everyone. I just thought I'd let you know that traffic chaos is reigning in all directions, as are the trains, but Edward and Keith are on their way. So would you feel happy if we delayed for 10 minutes? Or are you under pressure to get back? Okay, right. We'll make sure that happens. And Alison, are you happy with that? We're going to delay, Elaine even, we're going to delay by 10 minutes. Right, good morning everyone. I think we can make a start, and I'd like to say thank you to all of you who've had a rather difficult journey, and we're still awaiting Sham as well, aren't we? Hopefully he'll turn up. There's been an accident on the A12 just to make everything worse. So for those who don't know me, I'm Councillor Liz Harsant, and I'm obviously chairing the meeting today. Welcome to Kelvin Cracknell from Ipswich Borough Council, who's substituting for Councillor Christine Shaw. The meeting is being broadcast live and is available to watch on the Council's website whilst we are in public session. And a recording of the meeting will also be available for subsequent viewing if there's nothing on the television tonight. Members of the public and the press, which aren't here, may record, film, photograph or broadcast this meeting when the public and the press are not lawfully excluded, provided due courtesy and respect are shown to others in attendance in line with the Council's published guidance. Now, we're not expecting any fire drill today, but in the event of the alarm sounding, please leave the chamber by following the fire exit signs at the rear of the chamber. Fire evacuation instructions can also be found on page 4 of the agenda. Can I please ask if you speak clearly and directly into the microphones and avoid placing things such as papers, which I'm just doing, or IT equipment in front of the microphone, as this will affect the sound quality on the live broadcast and in the chamber. And please, can you turn your mobiles and laptops on to silent if you have not already done so. So if we could start with the official agenda. There've been no applications to speak in this session. Apologies for absence. We've received apologies from Christine Shaw, as I've already mentioned, and Kelvin is here representing her, and we had a late apologies from Councillor Miles Rowe. Declarations of interest and dispensations. Can I ask councillors, are there any declarations of interest? Thank you very much. Minutes of the previous meeting. Is the committee happy for these to be signed as a correct record? Thank you very much. And then we'll move on to item 5, the Essex and Suffolk Elective Orthopaedic Centre update. So the centre opened in November 2024 at Colchester Hospital in the new purpose-built Dame Clare Marks building. The Scrutiny Committee has been monitoring the progress of the centre's development since it was first proposed in 2019. The centre treats patients from the East Suffolk and North East Essex area, and also some patients from West Suffolk. This scrutiny will allow members to consider how the new centre is performing just over a year since it's opened. And you've got your papers, which hopefully you've been able to look at, a covering report by one of our senior Democratic Services officer, and an evidence set one contains responses to the questions in the evidence set and has been provided by East Suffolk and North Essex NHS Foundation Trust. Welcome, Shannon. I know you've had a bad journey and it's very kind of you to come. So can I welcome all the panel members? Perhaps you would all like to introduce yourself. Karen, could we start with you?
Yes, good morning. My name's Karen Luff and I'm the Chief Operating Officer for ESNEFT. Thank you.
Good morning, everyone. I'm Jan Engel. I'm the Deputy Director of Communications and Engagement, and I support Karen and the Executive Directors. Thank you.
I'm Luke Mussett, and I'm also working on the communications team at ESNEFT.
Good morning, everybody. I'm Simon Morgan from the Communications and Engagement team within the ICB.
Good morning, everybody. I'm Elaine Wheeler. I'm the Interim Senior Operational Manager for the Orthopaedics at the West Suffolk Hospital.
Hi, my name's Sham Chowdhury, and I'm the Head of Ops at Dame Clare Marks SEO.
much.
Thank you very much, Chair. So, good morning, everybody, and thank you very much for inviting us here today to do a reflection, really, on the last year of our Dame Clare Marks Centre. Just for clarity, really, obviously, East Suffolk and North East Essex Foundation Trust is made up of 2 acute sites and 7 community sites. We obviously serve the population across Suffolk and North East Essex. The Dame Clare Marks Centre, as I recall coming to a HOSC previously and talking about the 7 years that it took from idea to conception and delivery. So it was a very exciting project and one we welcome for all the population across our system. The Dame Clare Marks Centre is really dedicated as a regional hub for orthopaedic surgery, so for all bone and joint work, primarily for knee and hip replacements, but many other procedures also take place in there which involve upper limb as well. You'll see in the paper that we've outlined really some detail around our first year, so I'll just pick out some key points if I may. We've treated just over 5,000 patients. They are largely patients from Suffolk and North East Essex. West Suffolk patients are also included when I talk about Suffolk. And when we opened the Dame Clare Marks Centre, we had a collaboration and a working arrangement and agreement that we would 5 lists per week that sit within that unit are dedicated to patients from West Suffolk specifically. Since that point, we've also welcomed patients from Mid and South Essex hospitals, so we are developing those regional pathways, and that hub is, and the Dame Clare Marks is obviously expanding as a hub. We have a model of care which is outlined and consistent for all patients that are treated within the unit. That helps support patients pre-workup for surgery. It also helps them through their surgical pathway and then any post-op rehabilitation that they may require. Consistency is often good for recovery, and we can see in the outcomes for patients that pre the Dame Clare Marks Centre and pre that model of care, we were probably on average seeing our length of stay for patients to be around 4 days, maybe 3.8, and we can see that we have reduced that significantly within the Dame Clare Marks Centre, down to, on average, it's about 2.9 days for patients. Some patients who have hip and knee replacements, well, mainly knee, but do actually go home on the same day, so it all does obviously depend on the individual patient. As I said, we are welcoming patients from across all of the region. You will be aware, I'm sure, of the national waiting standards and times, and pre our Dame Clare Marks Centre, our average waiting time for orthopaedic patients was around, we always delivered the national standard, but was certainly at that upper level of that national standard, and could, for patients waiting is a very long time, their quality of life, and that consideration of 65 to 70 weeks was a long time for somebody who's in pain. We're delighted to be able to say that we are pretty much, for most patients, treating patients within the national standard of 52 weeks. Do not get me wrong, that's still a very long time to be waiting for patients, a whole year for a procedure, particularly with some of the mobility issues that this may bring. Obviously, nationally, the standard is that by 2029 we will be delivering an 18-week standard again, which will be a much improved approach for patients. For our patients in Mid and South Essex, we were approached by that region to ask if we could help support with the delivery of some capacity to help support their waiting times. Currently in Mid and South Essex, it can be anything up to 100 and 104 weeks. So for patients in that particular region, it's obviously a 2-year wait, and it's really important that as a regional hub we help support that parity across the patch, so that patients have a much more equal waiting time. That won't affect our own patients, we're still able to treat those patients within that time frame. You'll see also in the paper some of the detail around the consultation process that we went through, which I know that we've talked on previously here, so I won't go through that. And then finally, I just wanted to talk a little bit about our electronic patient record, which we launched in October last year, which is known as EPIC. And it is, I would say, very epic. It's a national electronic patient record system, but it has the ability for something called My Chart. So it gives patients the opportunity to manage their own care within an app, should they choose to do so. Now, not everybody we know will want to use that as a basis, but it means that for our patients who do want to use technology to view their results, organise their own appointments, it can be interactive, they can do so through their own My Chart app, and we welcome that obviously into the SEOC Centre. I'm happy to leave it there if that's okay and take any questions.
Indeed, Karen. Sham, did you want to add anything to that?
No, I think I came here, I think it's probably about a year ago. I was here, and I think I recognised some of the faces on the panel. So, but no, I think we're still growing as a centre. We're still learning. Karen talked about some of the support that we're providing to the wider region, and we hope that those sorts of things will grow. We've seen a real upturn in some of our activity numbers since sort of September, October of this year, and we hope that will continue to grow. So we'll start treating more than what we treated last year. I think we've been a really valuable asset to the area. Over the last few months, West Suffolk have had some estate issues on their own site, and we've been able to help really, to provide that support so that patients continue to be treated, and providing additional capacity over and above that. So, yeah, I think it's a great centre to work in, a great centre to have in the area, and one that I hope continues to grow in the future.
So, members, it's now up to you to ask any questions and to be thinking about any recommendations that you might like to put forward. Keith, your hand is anxiously up.
Thank you. I'm from the north of the area, which you don't cover in Ipswich and Colchester hospitals, and I've seen the value of the orthopaedic centre at James Paget Hospital. What I wanted to ask was a simple question, really. Are you where you want to be, and what more is there to do?
So I think for the orthopaedic centre in particular, no, we're not where we want to be. We obviously had a business case that was set out for the opening of the unit. And as Sham says, we are continually growing. It has taken us, we always had a phased opening approach plan in terms of the numbers of activity that we would be seeing. That is also reliant on the level of workforce that we have, and we have grown our workforce during that period, and we continue to look to do so. We have realigned some of our activity so that we are delivering it slightly differently. And technology has moved on even in the year that we have been open. So where we had based our number of patients per list, for instance, on certain technologies, that's already changing because it's enhancing. So we are developing and growing alongside that. So we have set waiting times which are set nationally. We would ensure that we meet those, but we actually are looking to see if we can grow the capacity further. Most NHS trusts, and I've worked in several, offer capacity Monday to Friday. Very rarely do we offer weekend working, and there's a whole host of reasons for that, which I won't go into. But actually, it's obvious that the population, we all want to do things at weekends, so there's no reason why we shouldn't be able to offer some of our planned safe surgery over that time as well. So again, it's a big unit, it's a big resource, and it would be good to use that 7 days a week rather than 5 days a week, for instance. So there's always more to do.
Just before I take any more questions, Elaine, I believe I missed you out. You would like to just say a few words.
So I think Sham probably touched on a very valid point in terms of our estate and the support that ESNEF and SEOC have been able to provide us. So over the last 12 months since I've been, my post here, I'm currently the Senior Ops Manager for Orthopaedics, but my substantive role, I'm also the Service Manager for theatres. So I manage the theatre suite and the day surgery unit at the West Suffolk. And in the 18 months that I have been in post, we have faced, sadly, several issues in terms of our theatres, in terms of we've had to turn them offline, particularly our orthopaedic theatres with our laminar flow. And SEOC have been able to come forward to help support that, to be able to move some of that activity. So it means we've been able to protect our patients, to be able to still deliver the treatment to them, most importantly. And most recently, we've actually taken both of our elective theatres offline currently, because they're both undergoing a full refurbishment, in order that we don't experience some of the issues that we have been experiencing with the temporary issues. And again, SEOC have been able to provide us with that additional capacity, so we are able to continue to treat the patients to achieve our standards for 65 and 52 weeks. I think that covers everything.
Thank you. I'm sure that's most helpful. Yes, Edward.
I just wanted to know, what do you think the morale of the workforce is, and do you think, because I know this is important, because otherwise if you don't keep up with this, they go, don't they? So have you taken out any surveys, any staff surveys, or
So I'll respond to that. So when we opened, there's a national staff survey, but when we opened, we had missed the deadline for that national staff survey, so we didn't have any baseline data to bear, to review staff morale and those sorts of things. So we did our own sort of shortened version of that, just to understand where we are. Generally, the morale is quite high. People that are coming into work are doing what they want to do, which is, surgery. They're not being pulled to other areas of the trust. We recognise that there are sometimes conversations we have to have with staff to say, actually, because of X, Y, and Z, we're running less activity, and you may need to move for a short period of time. But generally, the staff morale is quite good. The building has been built in a way that it takes into account a lot of those issues. So currently I'm going through, or we're about to go through, something called the hub accreditation, and we have to put forward all of the things that we do to meet what would be an accredited hub, and part of that is around our people and the services that we offer to them. So things like dedicated staff rooms, break rooms, and those sorts of things, lockers, and on all of those areas, we can tick the box and say an individual will have a dedicated space where they can lock their valuables when they go to work. They will have a dedicated changing room. They've got a break room where they won't be disturbed while they're having their lunch. So all of those little things help. So that's across the wards, the theatres, across the board. So those sorts of things are all helping with staff morale.
Thank you, Sharon. Karen, you wanted to come in.
Yeah, if I may, just to add to that. So I think it's important to recognise that the building was built with the input of the staff. So so you learn as you go through different buildings and different changes that are obviously different. There are different needs. So Sham's talked about some of those important things that our staff welcomed and wanted to see included in that new building. Obviously, if we could build a whole new hospital again and put different break rooms and showers and things like that are very important for staff in different locations, we would. But actually, for any new building that we design or are lucky enough to get funding for, the input of the staff is really important to understand how it works for them as well, because we want to help promote retention and recruitment. And we have seen particularly through the Dame Clare Marks Centre, a different level of applicant in terms of people coming from different parts of the country to want to come and work within that. So that also helps with that recruitment element, longevity, and resourcing it for the future. So I just wanted to really add that point. Thank you.
Thank you, Karen. Inga, I believe you have a question.
Yes, thank you. I just would like to ask, on page 29, paragraph 34, it says, additionally, not every patient staying on a ward or being discharged would have had an operation at the centre. And so it says that could be a violation of reasons why they are in a ward. So can you explain a bit more about that? Because I thought, you know, it would have been, they would have had an operation in order to get into a bed at the centre.
Yeah, so I'll take that. So there will be some patients that we've admitted who haven't been operated on. So we've had, you know, we have cancellations and those sorts of things. We recognise that there are patients who've attended that, you know, come for surgery for whatever reason, and there are various reasons, don't go home having had their operation. One thing that we're really keen to do is when that happens, there's always a senior person or senior clinician talking to a patient to explain if it's a clinical reason, here, this is why it's happened. If it's a non-clinical reason, this is why it's happened. And then we do our level best at the time that that patient is going home to give them an alternative date when they're coming back for surgery, so that we can, you know, we can say it's not going to be here, you're at the top of the waiting list and here's your new date.
Could I just say, I would assume that as it's day patients, you would have been able to let them know beforehand, because for some people it would have been a long travel to get there. So how often does it happen?
Yes, we track the on-the-day cancellation rate. It's been roughly at about 6%, I believe. I'll have to look at the data again, but roughly around about that 6-7% on the day cancellation rate. And it happens for various reasons. Whilst we are an elective centre, there are people that are cancelled on the day just because there are clinical issues relating to things that have happened. And we have, you know, surgeons and anaesthetists review a patient on the morning, and people have their medical condition might have changed somewhat from the point at which they were pre-assessed. And they get reviewed. One thing we do to try and reduce our cancellations is we do something called a TCI call. That's done, it used to be done at 4 days, and we used to find that there was a lot of things that were happening when we were calling patients at 4 days that required them to come in and have an additional MRSA swab or CP screen or a blood group and save sample or those sorts of things. So what we've done is we've moved that out to 7 days to give us more time to react to any issues. So what we do is try and minimise that. So we have a 7-day TCI call that gives us 7 days for anyone that's coming in, if there are issues that we're aware of, to try and resolve them.
Thank you. Yeah, Inga.
Could I ask another question for now? What about the waiting list? We heard that West Suffolk has got their sort of own list in a way, of their own surgery. What about, because of course for us it was about SNF patients, you know, so that's the Suffolk bit of which SNF cover, and then the North Essex bit. Do they have a special waiting list? And of course I'd love to know, what is your waiting list for our patients here?
Shall I take that? So the waiting list that we have for the Dame Clare Mark Centre for Orthopaedics consists of any patient that's transferred over into the unit, irrespective of where they're coming from. They sit on our waiting list, because it's obviously important that we can see that patient and report on that patient through the system, and then because their treatment is delivered in that unit, then their outcome is recorded on the system. So when a patient is coming from a different location, West Suffolk, Mid and South Essex, or some patients choose to come from different locations into the unit, then we record them on what's called a PTL, which is a patient targeting list. That's very common throughout the whole of NHS. That's not just unique to SEOG, but that's how patients are tracked through the NHS. And then through that process, they will all of their interaction across their pathway will be recorded, and then they'll be discharged. So in terms of the total number of patients, our total waiting list for the organisation is just over 87,000 patients. For orthopaedics, I haven't got the actual number to hand, but I can tell you that we've got only 63 patients for orthopaedics on that total PTL who are still yet to be dated to meet a 52-week standard. So by the end of this month, those 63 patients should be offered a date, and then we should have no patients waiting beyond that year. Now, they could be patients from West Suffolk, from wherever, because they're sitting on our PTL, for want of a better word, sorry to use that acronym, but because they're sitting on that patient list, the responsibility of their care sits with ESNEFT to deliver their care within that national standard. I don't know the total number off the top of my head of orthopaedics. I could probably have a quick look, but if that's helpful.
Thank you, Karen. That sounds like really good news, doesn't it? Mary.
Thank you, Chair. My first question is for Elaine, actually. I sit on as an observer on the Future Systems Board at West Suffolk. How does this service fit in with all that's planned for the future? Thank you.
So do you mean how does it sit? How does the SYOC sit within the new? Yes, it is. It is part of the provision. So, as my understanding, there is no plans to change that. So it will continue as it. The agreement will continue as is. There should be no change.
Can I just follow that up?
Yeah, sure.
The response. You have a lot of users for the West Suffolk Hospital. There's a lot of response from the community. What is any of them that have used this service? Has there been any response from them?
So it's a very positive response. I think the key point is that patients are waiting less time, and I think that's the key. I think, as Karen mentioned earlier, we're talking about patients that are in pain, that they would like their treatment. They're going to a dedicated orthopaedic centre to have their procedures. We do have a small number of people or patients that have potentially some issues in terms of the logistics of getting there and back, but that is small, if I'm honest. It's mostly led by the aftercare for people that live on their own in terms of there and back and transport, but it is small. Mostly we have a very positive response to the orthopaedic centre, which is really good.
I'm always impressed with the communications that West Suffolk Hospital have with their community.
Yes.
There's a lot of interaction, isn't there?
Yes, we're very proactive in trying to ensure that our patients are kept well informed. Yes. You're very welcome.
I'm sorry, I'm suffering from whatever. I brought up on my laptop about the CQC report for Colchester General Hospital, which happened.
Not
the report
sure
was
that that's really relevant for this meeting.
Sorry?
I don't know whether that's really relevant for the meeting.
Well, I just wanted to ask about how that had impacted on this service. Is that not a legitimate question to ask? I'm not commenting on the report, because you know the report. I'm just asking what impact that had on your service.
So when the CQC came to do the inspection, they didn't actually go into the Dame Clare Marks Centre, so it's obviously any recommendations that come through the CQC report will be applied across the organisation, irrespective of where it was found or not. But actually, in terms of their visit, they didn't physically visit there. And just while I have the floor, if I may, the total number of patients on our trauma and orthopaedic waiting list is 7,987, just for clarity, out of that total 87,000. I had a quick message. Thank you.
Any more questions, Mary? I'll ask it in any case. You obviously employ, if that's the right word, surgeons from around the county, and we often talk about issues like we've had today, transport, how does that affect your day-to-day surgery? You know, how do you cover if there is a bad accident or the Orwell Bridge is closed? You know, how do you deal with that with patients?
Yeah, so first of all, we've run a few campaigns, just to go to the beginning of the part of the question, and we've had some really good applications who have come when we've tried to employ some surgeons. I believe, Karen, you were lucky enough to sit on the interview panel for the last set, and we had some really good candidates who have done international fellowships, who have applied to work at ESNEFT and work at Dame Clare Marks. And that's one of the reasons is that we have such a large surgical hub on site that they will be doing their elective operations. So we have a really good, it's got pulling power, I suppose is the word. So how do we deal with issues that happen on the day? It's like any other operational issue that we have on the day. We look to firefight and resolve as and when we can. So we'll do whatever we can to try and ensure that if a patient has turned up for treatment, that they get the treatment they want. Now, sometimes that's not always possible. I talked about, patients who have changes in clinical conditions and stuff like that. So, it's not safe, but where we can, we will pull together and we will work with our other surgeons who are in the centre to ensure that a patient goes home, that day or the day after, having had the treatment safely that they were planning to come in for. So it's an operational thing. One of the reasons I was late is because I've been on site this morning, so we always have an operational lead on site quite early in the morning to try and do that firefighting, because our surgeons turn up, our anaesthetists turn up at around about 7:30 to start that initial process, to start their theatre, and usually you need someone there quite early in the morning to assist and do that firefighting if there are any issues. So yeah, that's flexibility and firefighting.
And in this day and age, we have to work around traffic problems, I think. And I know Miles, I think, wanted to ask this question, and he's not here, but with all the changes in local government and border changes, etc., how is that going to impact on patients' experience?
So I think, we welcome any changes that are proposed. We obviously work very closely with colleagues and changes. We've internally, obviously, we have a new chair of our own board starting next
Monday.
week. Yes, we work alongside colleagues to ensure it doesn't have an impact on the delivery of care for patients. Importantly, everything that we do is done with a patient at the heart of each discussion. So from a political point of view, we certainly welcome the changes that are being proposed for patients waiting, for instance, over the next 2 years, and that improvement, not just for orthopaedics, but for all specialties. I think that's important to recognise.
Thank you. Is Inga?
Thank you, dear. I just wonder, as surgeons come in, different surgeons has their different lists, but I remember back to when there were certain nurses that worked in surgery, they worked for certain consultants and so on. I assume you employ your own staff that just work for whoever come in to operate. The surgeon that comes doesn't bring any staff with him or her, so you have staff there, anaesthetists and all the staff you need in the surgeries. They are just there and work for whoever come in. Is that how it works?
Yeah. So essentially, we have what we call the theatre team. So we have an agreed level of staffing for each theatre that consists of, we call them ODPs, operating practitioners, and then we have scrub teams, who are the people that get the equipment out. What we have is groups or these teams who work regularly with surgeons. So where they're employed by the centre, they work in the centre, but Mark Loeffler, who's one of our surgeons, knows when he comes in on a Monday for his list, he's generally going to be working with that same team, you know, bar leave or sickness or anything like that. And then they get used to knowing how each other works, and it helps with the efficiency and everything like that. What we're now going through is a process where those teams are now starting to circulate through other services to try and improve their skill mix, to build our own resilience and what have you, so that they get more familiar with different surgeons. But it's not to say that one team can only work with one particular surgeon. So yeah, the surgeon turns up, we have a set theatre team that they're used to working with, and they get on and do the job.
Sorry. And how many other surgeons do you have that come from other hospitals in Essex or Norfolk, Suffolk, wherever, that come in with their, I assume they bring their own patients with them, or they come and operate? How many from the outside team?
Yeah, so from West Suffolk, Elaine's here, so she can correct me, but there's about 12 regular surgeons that come very frequently. In addition to that, there are a couple of, maybe more than that, surgeons who maybe are less frequent, who come once every other week or once a month. But 12, what we would call arthroplasty, so do hip and knee replacements and those sorts of things, surgeons who are regular attenders from West Suffolk at SEOC, and who frequently we'll see on a given day operating. Then from Mid and South Essex, we have 5 surgeons who operate at the centre. We've tried to increase that, but for various reasons, we've decided 5 is a good number, given the number of lists that they do. They don't do a huge number. And when you open it up to a number of surgeons, the less infrequent they come, or the less frequent they come, the more inefficient those lists become, and they often find that actually they prefer to come quite frequently, and hence why we've kept that group down to a small number.
And if I may, we don't generally see any other anaesthetists come from across the patch. We actually employ our own anaesthetists for that unit. So again, a bit like that team approach, then you get that consistency, which I think is really important for patients and for the surgeons. So it and longevity and training. So it supports all of that staff retention as well, which is important.
Did you have one more question? No, Ed, you wanted to ask.
Thanks very much, Chair. I think I probably know the answer, but I just wanted to confirm. The graphs that are on pages 27 and 28 indicate very low levels for November 24 and December 24. I assume that's simply because the system was coming on stream, and obviously at that point there weren't that many people set up to actually have operations, etc.
So we planned from the opening in November 24 so we have 8 theatres within the unit, but we planned to open them gradually, and we also expect to have a set amount of patients per list, but we also reduced that by half to start with. Really important that the teams became familiar with the new working environment. Many of our surgeons had worked for us for many, many years in different theatre environments, and because of new technology and all of that, which is brilliant, but actually it does mean you are using different equipment. So it was really important from a safety perspective that we put that phased approach in. And I will say the building itself was very new, so we operationalised that whilst commissioning it from about August onwards, August onwards. So we were still having builders in the building in October, whilst we were still we were making sure the equipment was fitted. So it was an interesting time, and but it also meant that from an opening perspective, we wanted to do it in that phased approach, just to test the building as well, test the flow, make sure that our sterile services department can get backwards and forwards in time and things like that. So that's why there is definitely less patients, and you can see that building throughout that period. Thank you.
Thanks very much.
Mary.
Thank you. Just thinking about this specialist service, and you know, it's wonderful what you're providing. Is that attracting young doctors and young surgeons to the centre? Because we hear in this committee, we often hear about the difficulty in recruiting medical staff, and I'd like to know how that is going on.
So the last interview panel that I sat on, we interviewed 12 candidates for 4 jobs, and we were attracting international candidates as well as those from the UK. So it was a really strong field, and that's not just for surgeons either now. I actually was on a panel about 3 weeks ago for anaesthetists as well, to be based at Colchester, not just for the Dame Clare Mark Centre, but also, you know, for other specialties and other theatres. And we interviewed 8 that day as well, and were able to appoint 3. So again, both nationally as well as internationally. So I think the regional hubs, whether that be orthopaedics, whether that be surgery, endoscopy, they do attract a different calibre of people, and I think we can demonstrate that people want to come and stay in the location and give back into that local community, which I think is really important.
May I just add something to that? So I think the other thing we're really lucky within our hub is we have some dedicated training and seminar rooms. So things like the East of England deanery teaching, we often do that at within our hub. So we encourage the training doctors in trauma and orthopaedics across the region to attend these deanery teaching days. We have, I talked about hub accreditation. One of the clear points is that there is an opportunity for doctors to learn at these hubs and get that experience, and we've been really critical in doing that. So one of our surgeons, Tim Parrott, got Trainer of the Year last year, or this year, when it came to the East of England. And we are keen to ensure that everyone has those opportunities to use the lists and train. We've got some really good surgeons who are happy to provide that at the elbow training, as well as saying, I think you're confident, you're competent, and talking to me and my colleagues and saying, we'd like to give those trainees their individual own lists, which has been really good, and it's got their skills up. And in addition to that, we've got a couple of clinical fellows who are working within the trust. So these are people that have post-CCT, so got all their medical qualifications, and are now doing the final bits of training before they become sort of consultant level practitioners, essentially. And we've got a few of them that are doing activity in the hub, and it's something that will continue going forward.
Thank you. Do you provide accommodation for staff? Because I know in Ipswich you've got Pearson Road.
Yeah, so I wasn't aware, but Karen's telling me yes.
Yes.
So yeah.
Yes, sorry. There is accommodation available on both our acute sites for trainee doctors, but also as well, Shannon's also talked about doctors, but we're also doing internal development leadership courses as well, which also helps that longevity for staff. So, but yes, there is accommodation available.
Just before we go on to recommendations, one of you said about the aftercare, and somehow it's quite difficult for some patients without transport or without families to be able to bring them into hospital Ipswich. How do you deal with that?
So I think that's mainly an issue for patients that are travelling from West Suffolk. When I've spoken to colleagues in the past, I think that the fact that their travel, I know they're going to have some difficult, longer travel times, but the fact that they're waiting less is a key factor. But generally, West Suffolk have always had the opportunity for patients who cannot travel for whatever reason to have their surgery. So, you know, we talked about 5 lists a week. That's some element of that. That's been increased to support whatever issues West Suffolk have, but there's always been some retained trauma and orthopaedic capacity on the base hospital for those patients who just can't travel.
Can I thank you all for... Oh, sorry, Inga, you've got one more question.
Sorry, yes. I just wonder, when you get patients in from outside the area which our ICB covers, does the hospital get extra money for that, or do you get in? And then I have another question, which, as you mentioned, the new app for patients. Somebody asked me, do you know where that information is kept? Which, you know, because people will clearly have their information there. Where is that kept and who is it shared with? It's maybe not something you can answer here now, but I think that is certainly for some of our residents an important question. So if you can't answer now, then, you know, that's fine. But I think that's something you know, ICBs and so will come up against. Where is information kept?
Shall I take the second part first? So from a MyChart perspective, it's a bit like the NHS app. So it will be secured on it'll be stored on a secure servers. I wouldn't be able to go much beyond that, to be fair. I would say that it would go through our Caldecott Guardian, which would be, from an information governance perspective, it would have all been signed off through our governance processes within the organisation. So in terms of how to safely store, information on patients. So Luke might be able to come in probably a bit better than me. My technology limitation probably stops there, sorry.
So with MyChart, yes, on our website we do have information on there as well. I can't honestly recite it, but we have had queries in the past from members of the public because it is public information. But what we can do is we can prepare a short paper if the chair would like, and yourself as vice chair, just explaining how the information governance works on MyChart, if that would give some reassurance. Yeah. Thank you.
What was your first question? Sorry.
It was whether SNF get paid extra money from the patients.
Sorry, yes, I went straight for the second one, sorry. There is locally agreed tariffs for patients that are nationally agreed tariffs for patient procedures, sorry. We wouldn't get any enhancement because of that. It's a national tariff for a procedure, so that money would be paid into what's known as the Integrated Care Board, the ICB, and then we would draw that commissioning down from them for those particular patients. There's nothing additional for it, but I think what's important is that patients are treated, timely and equitably, which is, what hubs are all about, really. Thank you.
I'll try again to thank you very much indeed for coming this morning. We go into a conversation now about recommendations. I'm not sure that we're going to have an awful lot because it seems that things are going very, very well. So congratulations on that. Please feel free to stay, but I know some of you have got meetings to go to. So we could take a 5-minute break if that would suit everybody. Thank you, everybody. Can I just ask members if they have any recommendations they'd like to put forward? Yes, Keith.
It's a bit difficult because this is more of an update than a full scrutiny, but I would congratulate them on their efforts so far and support them in their future endeavours. But waiting list needs cutting down on a national basis. There's no doubt about that. But carry on.
Thank you. I'm sure that the panel are very pleased to hear that. Inga, did you want to put something forward?
I certainly think we need to keep an eye on and learn. And of course, for us, we are interested in the patient from Suffolk, you know, because, you know, we don't know what the future will be and the ICBs will change or whatever. So we need to be sure that in the change to come with the ICBs and changing, that we don't lose out in Suffolk. And that's certainly something I would recommend, that we get back and hear once it's settled, you know, how it's going, because I don't like having neighbours who can't walk and have to wait for years, and I'm sure that's what come from all of us.
Mary, have you got any?
I'd just like to add my congratulations to the team. It was nice and reassuring to hear how successful you've been in this day of gloom and doom, really, around health. So it was, I enjoyed your report. Thank you.
Edward?
I just asked if there's anything that you could possibly think we might be able to help you with, perhaps add some connections into the counties, and for someone to go and see something, or then please come and ask us, okay?
Thank you very much, and thank you all for your really positive comments. I think the role that you play as elected representatives, and actually gently but firmly and constructively holding us to account for the care that we deliver to the communities we all serve, is so important. And I think I would say, please keep on doing that, because it's really, really important that we have this dialogue and we are able to demonstrate what we do, but we're also most importantly able to listen and take on board the views of your constituents and residents that you represent. It's really important, I think, that we have this two-way conversation, and I think talking about what we are doing to improve, talking about what we're doing to really deliver much faster care, which is every one of us, that's our aim, is to deliver the best care as quickly as possible. So thank you.
And during the break, we just had a quick conversation about aftercare, and it's amazing actually what you do. The Red Cross go into people that haven't got any transport, and that is so good for isolation purposes. And you were going to tell us about the voluntary bus that you've got, because I think a recommendation could be that we hear more about aftercare, because it's something don't hear a lot about, Jan.
Yeah, thank you very much, Chair. Yes, there's an awful lot of work that we all do. So this is a collective NHS. So our Integrated Care Board Commission and fund lots of innovative work in the community. And I wondered whether you'd find it interesting to have a presentation at a future meeting looking at how community services actually support patients leaving acute care. Sorry, I've really jogged me. So leaving hospital, what that support is like, because we have both West Suffolk and ESIOC have community neighbourhood teams. We actually provide community services, but we also work in partnership very closely with voluntary agencies and charities in the community. So in North Essex, for example, we work with Tendring Community Services to provide what they call hospital hopper buses, and we have worked in the past with Suffolk providers to do the same thing. So I just wondered, Chair and members, whether you'd find it interesting, as a follow-on from our presentation about ESIOC, to look at how we provide that aftercare. And that is very much a partnership approach and I would be very grateful if we could all be invited by Suffolk as well, and perhaps some of our voluntary agencies that we work closely with.
I think we would really appreciate that. Thank you, Jan, very much indeed. So I don't think we have any other recommendations. Isn't that good? No? Moaning? Nothing. So thank you again. Simon, you wanted to come in?
I did, yes. I was leading the engagement when we were moving some of the services from West Suffolk to the ESIOG, and I just wanted to say that we had nothing but support and real assistance from the HOSC, and we were very grateful to all your help and support back then, and we remain so now. So I just wanted to say thank you again, and go back to Councillor Thompson's ask about how the group could assist going into the future, continuing assisting us going into the future. Please promote the service within your patches. That would be really helpful, I think. Do you agree?
Yes.
Thank you. Thank you very much.
Thank you very much. And safe journey back to wherever you're going. Thank you very much for coming. Members, we've got item 6 on the agenda, which is reports from board observers. Do we have any contributions with that? Mary?
Sorry, Chair, the Future Systems Board were meeting this morning, so I had to give my apologies.
Inga, have you got any?
I hope I managed to get to a bit of SNIFT meeting on Thursday. Thursdays are not always the easiest day for me, but I hope to be there some of the time. But what I'm sad is I looked just as late as this morning to see the agenda, and it's still not on the public website. It comes out so late, and I think we need to do some chasing up with them to be sure that the agenda actually come out, because, you know, without knowing what's on the agenda, you can't really prepare for going to a meeting.
That. So you're saying that we need to bring that up with them?
I think, you know, with them, that it would be really useful if they could, because there could be other people than me who look at that. Yeah. Sorry, I was saying the agenda for SNAFT's board meeting, they have it on Thursday, and it's here in Suffolk on Thursday. But the agenda is not yet. I looked as late as this morning, and it's not on the website.
Definitely, we'll bring that up. Now, the forward programme. So the next meeting is the 1st of July, and some of us might... Sorry? Information bulletin, I believe we have that, don't we? So have I dealt with that item 6? No information bulletin. Sorry. So with the forward programme, which is item 7, the next meeting is the 1st of July, and some of us will be here and some of us might not be here. We do not know. So for any that are retiring from the County Council, thank you very much for being part of this committee. And for those of us who are seeking re-election to the County Council, all I can say is good luck. And that goes for myself as well. So I can't make any recommendations for the forward plan, but I think when we've spoken at briefing meetings, we do think that we ought to invite the panel back to talk about the I get this muddled up, the CQC report. Do you agree? And Keith?
I'll just say, I mean, it's only a suggestion. You know, I do health education scrutiny, and because of the way things have panned out, what we decided to do is have a workshop on the next date within introductory, and we are going to put forward some options for them, items in the forward work to be picked out for the forward work group. They can pick and choose. We can't dictate to the next scrutiny committee what they do, but we can give them every help to get started.
We can't tell them what to do, but we can leave behind a recommendation or two, can't we? Yes. And we, yes, I was going to say, and probably the new committee could ask for the new CEO of SNEFT and the chairman, Tracy Downing, to come in and introduce themselves. I think that would be a good thing to do. So I'm afraid we'll have to leave that one as rather vague, because we did promise that we'd do that ambulance workshop as well, which again we can leave that as a recommendation for the future committee. So that brings the meeting to a close. So I want to thank you all very much for attending, and I'm sorry that some of you had such a horrible journey. I hope it goes better going home, and I won't mention the next meeting, the date of it again, because we don't want to go home depressed. So safe journey home, and thank you.